Good afternoon, everybody, and welcome to this webinar that is being hosted jointly by USANA and SAPA. And welcome to everybody that's joined in from South Africa and beyond. And thank you to our co-hosts, SAPA, for hosting this webinar together and allowing us to use their platform. And as this is a month for honoring and celebrating our preterm infants, I would also like us to just remember those infants throughout the world who are affected by conflicts and our colleagues who are working in very difficult circumstances trying to look after them. So I'm not going to stop for a minute, but I would just like us to acknowledge how privileged we are that we are able to work and look after our patients. Before we get into the main proceedings today, on behalf of the USANA Executive Committee, I'd like to take this opportunity to launch our USANA 2024 conference, which is the 6th biennial conference of USANA, which will be held in the Drakensberg next year. And this will be preceded by 3 workshops on ventilation, quality control, and feeding. And to launch the conference, I'm going to ask my colleague, Dr. Shakti Pillay, who's the conference organizer, to play a short video. Shakti, over to you.
Thanks, Gugu.
Thank you, Shakti. And before I introduce our speaker, just a few housekeeping comments. So people can post questions and comments in the chat, and Shakti will help us with coordinating the questions. And at the end, we'll have some time for questions for Professor Lon. So without further ado, let me introduce our guest speaker. Professor Lon is, we're very honored to welcome you to speak to us on this as part of our World Prematurity celebrations. Professor Lon is an African-born, British-trained pediatrician and perinatal epidemiologist with 30 years experience working notably in the sub-Saharan African region with global organizations such as the WHO and the UNICEF. And she's also a champion for equitable and diverse research leadership in child health services. Her main contributions to global health have been developing the evidence base to measure and reduce the global burden of 2.3 million neonatal deaths, 2 million stillbirths, and 15 million premature births, including informing some of the Sustainable Development Goal targets. She's very well published with an H index of more than 110, including several of the Lancet series publications and United Nations reports on perinatal health. And some of the work she is doing, she and her team are doing, involves implementation research on small and sick newborns, and involving working with the NEST 360 network, which I'm sure she will tell us something about today. So Professor Lon, welcome, and over to you. Your sound is off.
Yes, you would think after 3 years on Zoom, I would be able to do that immediately. So first of all, Gugu, thank you. And thank you, everybody who's here. What Gugu didn't mention is I had 8 of the happiest years of my life based in Cape Town, and actually had the honor of playing a hand in the conception of Usana. And I see that Alan Horn and many other familiar names and friends are on this webinar. And Usana was born out of Sapa, as all of you know, in 2008. And the vision at that time was to go faster in South Africa for neonatal survival, but also so much learning that could be shared two-way across the continent. And I know that in my time in Cape Town, I learned so much from many there. So what I'd like to consider together is how can we go faster together in South Africa, and how can we enable much faster progress across the continent for many neonatal deaths. And in that, I want to bring a lens for World Prematurity Day. So I noted that this is the 15th World Prematurity Day. It's also 15 years old for Usana. And yet we still have 13.4 million born too soon, flatline for progress, and really critical to do more. I want to start from where we all start. So all of us enter the world similar, naked, vulnerable, whether we were term or preterm. And in 2021, the most recent year that we have estimates for, about 134 million live births. So our total birth cohort for the world has peaked at about 145 and is now dipping, apart from in the continent of Africa, where it's still increasing. And of those babies, about 30 million will need some type of special care. But if we look at what happens next, not all babies are equal. So there are about 10 million that are born in high income contexts. And that is where most of the focus of neonatal care has been in the 50 years or so that we've had neonatal care. If we look at Cochrane, nearly all the neonatal reviews that are there and evidence trials outside Cochrane particularly focus on an incremental gain, often now for smaller neonates at the thresholds of viability. And when I was doing neonates in the UK, you know, we still weren't getting good results for 23, 24 weekers, but now most 24, 25 weekers will survive and will have mainly disability-free survival. So this has been the focus of neonatal care. But if we look around the world is changing. More countries are moving into upper middle income countries, and South Africa is in that bracket. China, India is moving towards there. And this is about 40 million births a year. And in this context, actually, many of our challenges are around over-medicalization. I've just been in Brazil a few weeks ago, where the cesarean section rate is 53%. So normal birth is a cesarean section. And this brings different types of challenges, both for women and also for babies. But we still have the majority of births in low and middle income countries. And around 34 million that are at home. So the number that are happening at home has halved in the last decade. Big shift into facilities, but this is still a huge number and for the poorest and with the least data. These babies may enter and leave the world without a single piece of paper, and yet we have to be accountable for them. And then we have this shift, graduation, from home to facility birth. And I spend most of my time working across East and West Africa. We now have about 50 million facility births. And in this context, we have not really changed the facilities that women are coming into to give birth. We've not really changed the neonatal care. It's really lagging behind. And so this is a picture from Uganda, where I often work, where we really, are overcrowded with really sick babies next to each other. So on this page, you can see the world, the inequalities that we have, the gaps that we have. And how do we as clinicians and scientists move this forward? And a really critical point here is that we need to generate more context-specific evidence. We can't just take things that work and are proven in a context where we have high levels of nurse to baby ratio, where we have a lot of devices and very different care. I was in Karolinska just over a week ago, and I felt like I had gone to heaven for the neonatal unit there. It was amazing. We can't just take evidence that is generated in these contexts and drop it into middle-income countries, let alone into low-income countries. So how do we take this forward? So I want to start by saying, well, where are we with the political traction and targets? First of all, just to underline where South Africa sits in this. So about 1.2 million births a year, 13,000 neonatal deaths. This is still a lot, but across Africa, more than 1 million neonatal deaths. And in fact, that number hasn't changed in the last 20 years because the birth cohort has continued to go up and the neonatal deaths really have not come down enough. So this is critical, and it's critical because it is preventable. It's not just a tragedy, it's an unacceptable gap that can and must be changed. And we have a different opportunity for changing that because of political traction now. So I know that in South Africa, the great love of sports, and congratulations on the recent Rugby World Cup. What is our score at halftime for the Sustainable Development Goals? Well, we have a target for maternal deaths, and that target has been in place now for more than 30 years. We have made progress, but we still have around 300,000 women dying each year that really are very preventable, and this should be unacceptable. For child deaths, we have made major progress after the first month of life. So we used to track just the first 5 years, but now the global focus is up to 20 years. And from the first month until 20 years, about 4 million die. Still from preventable causes, which I will come to in a second, but massive trajectory for change. And now, still newborn on the global agenda, we have 2.3 million neonatal deaths. And they're there not because you or I as clinicians have a powerful voice, and the socio-political scientists tell us actually we're too nice about this, much to be learned from the HIV movement, and it would be great to hear your thoughts on that afterwards. These deaths are on the global agenda because we now have a target. So for the first time in history, we have a neonatal survival target due for 2030, so really only 6 years to go. And still stillborn on the global agenda are the stillbirths. Almost 2 million, and this is counting stillbirths on the UN international comparable definition from 28 weeks. So the International Classification of Disease says we should count all stillbirths from 22 weeks, and then the comparison is from 28 weeks, just because that is more comparable at present because of thresholds of viability and data limitations. So this is 2 million. Shockingly, around half of those happen during labour. So utterly preventable and really linked to accountability. So as we move forward in the mortality transition around the world, more deaths are closer to birth, and those are the most vulnerable. Women are vulnerable, and babies are even more vulnerable, as we know too well. They can die in minutes. It's really a test of our health system. And it's just so distressing to look at the news and to see in Gaza unacceptable casualties for preterm babies who are the most vulnerable and innocent in that situation. So in total, 9 million deaths of women, children, newborns and stillbirths, and many threats, both with conflict, but also with climate change and economic crisis around the world. And then what about Africa? So Africa, 13% of the global population, currently about half of the burden. And unless trajectories change because of increasing population in Africa and lack of progress in mortality, 6 years from now, when we come to 2030, it could be that Africa has 3/4 of that burden, and this should be unacceptable. So we have a huge gap. How are we going to close it? And this gap for mortality and for action also links to the research leadership, the implementation leadership, and the power at the table. So if we look at science around the world, less than 2% of published research has an African author. And I'd encourage you to look at this paper called Stuck in the Middle, because also gaps for where people are credited, which is really something that should be equally unacceptable. If we're talking about the inequalities for death, we also need to look at the inequalities for leadership. So as we go forward, what could USANA, what could SAPA do? And how can we intentionally change this? I'd like to draw your attention to this supplement that came out last week with newborn care leaders across Africa, with a deliberate focus on having 70% African authors and more than half female authors. And this is the sort of thing that we need to do to not just describe gaps in science and describe gaps in implementation, but to put together our learning from Africa and make sure that this is led in a way that leads change on the continent. So what about zeroing in on South Africa and South Africa's score at this critical halftime on the Sustainable Development Goals? Well, there has been progress made in maternal mortality ratio, especially since HIV and antiretrovirals have also included women. However, there are still about 1,500 South African women dying from maternal causes. There are still around 13,000 neonatal deaths each year. And particularly shocking, I think, are the stillbirths. So this is around 33,500 deaths each year, which rarely appear in our news. And there's underlying that a large number of newborns who are vulnerable and need hospital care, and they need it fast, and they need it with quality and with access that doesn't have barriers. So how can we go faster together? And from the really wonderful learning that is in your group here, how can we also bring that science and implementation for two-way learning across the continent? So I want to zero in on preterm birth as a driver of this. So this is the global pie chart for under 5 deaths. And in many ways, we live in a pie from the past. So in South Africa, of course, HIV has really dominated under 5 deaths, but has come down and is now a small share in South Africa because of both political commitment, investment, and actually implementing many things that we can learn. Globally, only about 1% now is AIDS. And if we look at this, in fact, around 1/3 of global child deaths are infections, still unacceptable groups that are in pneumonia and diarrhea. About 18% non-communicable, and this also is not getting enough attention, injuries and cancers coming up. But 48% is in the neonatal period. And because neonatal complications, particularly preterm birth, kill after those first 4 weeks, more than half of child deaths are due to neonatal conditions. And in the top cause of death now for under 5 deaths is preterm, and that's been the same for a decade. And yet, even amongst our own community, maybe we don't know that. Maybe we don't use that with others. And obviously, these conditions do overlap, particularly preterm and infections. This is preterm as a direct cause of death, particularly from respiratory distress as the leading pathway here. So if we look at this and move to the global burden of disease, not just deaths, but your lifetime effect of years of life lost and years lived with disability, the top condition in the whole global burden of disease affecting health is neonatal conditions, particularly driven by preterm. So this is 7.3% of all lost human capital. And I think that, maybe we don't know that or we don't use it. And really critical that we know our data and make the case. We're not just asking for attention to newborns because we like them or because we work on them. This is the single biggest condition in the global burden of disease, and it's unacceptable that there isn't more change. So if we then move to the underlying rates, so this are the most recent rates we published in the Lancet 200th edition in October, and were also used in the Born Too Soon report earlier this year. And in the top 5 for preterm birth rates is South Africa. South Africa is also the 13th highest number of preterm births. So this is really disproportionately driving where you are at the moment and for your neonatal outcomes, most obviously as a cause of death, but also for disability, including hidden disabilities. This slide gives you a number of key reports that have come out this year with different angles on that data, and I'm not going to go through these in detail. I would point you to the Lancet Small Vulnerable Newborn series, which with very big data analysis from across the world, we were able to look also at small for gestational age and the overlap, and really underline how important it is that we look at in utero growth restriction as well as being born preterm. So really critical, and especially important in South Asia, where this is a major driver. And then more details here on this flashing GIF on the right-hand side. If you can cope with that without it making you feeling like you need an anti-epileptic. The thing I would particularly flag here is the flat line for preterm birth around the world, actually with some increases in the numbers in Africa because of the ongoing birth cohort. So finally, this is becoming more of a political issue. And the reason that this got 3.5 billion media coverage, actually from the meeting in Cape Town in May this year, is not just because of the data, but because of the human stories. And this is critical. Every family in the world is affected by somebody who's born preterm. And really important that we recognize, just as was seen with AIDS, that it's often the personal stories and the personal stories within politicians whose families are affected. And that was very much seen in South Africa with AIDS as well. So how can we take not just the numbers, but also the human stories that we see in front of us in our clinical practice and link that to the data and to the politics? I'd really encourage you to look at this report and think how that could be useful for you. But in terms of moving forward to go faster, we have 2 pathways for preterm birth, and this is highlighted in the report. One pathway is primary prevention, so to reduce preterm birth, and the other, which is what most of us focus most of our time on, is to improve newborn care, including the preterm aspect. And unfortunately, we're really failing on preventing preterm birth. Flatline for a decade. There's only 5 countries with any statistical change over that time period, and that's at about 0.5% per year. And some of that may be because some of the risk profile is changing. Maybe climate change is shifting some of the things that maybe we had made some progress on, such as smoking. But overall, we're not succeeding, and we definitely need more work on the things that we can do, and also more science to drive faster change. But the thing we have in our hands is to close the gap for current survival for babies who are born too soon. There are things we can do during labor as well that do ameliorate outcomes, particularly antenatal corticosteroids. But the countries that have made the fastest progress for reducing the burden of preterm birth, it's mainly been about improving care for these babies. And this is an illustration of the very large survival gap. So it's a generalization that, you know, in high income countries, babies less than 28 weeks, more than 90% will survive. Here in the UK, that's probably closer to 98% now. And in low income settings, less than 10%. And in Tanzania, where I was last week, it's probably closer to 5%. So this is a shocking gap, and it's like the early antiretroviral days. But the good news is we actually could change this, and the political momentum is starting to come. So by implementing a core package for neonatal care, including the preterm components, we could reduce deaths by about 750,000 a year. And we must do that if we have any hope of reaching the Sustainable Development Goals. But to do that, we need to reach high coverage. Having a couple of teaching hospitals that have beautiful neonatal units, but not covering the country's districts will not work. So I want to move forward into saying, well, what are the science that we can bring into our implementation to take that forward? And I love this statement that I've put at the bottom here. If we want to go faster, both in research and in practice, we need to have unlike minds together. We need to be able to listen to each other, work together across disciplines. And the obvious one in neonatal care, where we're really understand the need for teamwork as with doctors and nurses as an equal team, but we also need biomeds and lab and other broader paramedical specialities. But in science, the same. We need to both be able to do better implementation research, but not knock those who are doing lab research. How can we combine and do better? To do that, we also need to understand where the money is. And often for research, we really struggle in responding to research calls. Most research calls have very low success rates, probably around 15% for many of the really competitive ones. So this slide is summarizing two papers that some actually really gorgeous young clinicians from around the world worked on to put together these large data analysis published in Lancet Global Health last month. And I would encourage you to go and read them and think about what we learn about the funding structures, because for HIV, changing the funding structures was really critical to making progress. So we've published these papers not for the sake of publishing papers, but to try and change who spends money on what and why. How can we have smarter funding? And we were actually pretty shocked to find there's quite a lot of money. How could that be allocated in a way that would have more impact? And how could it be led much more from the global south and particularly from Africa? So I want to zero in not on the donor funding, but on research funding. So to do this analysis, we looked at the Dimensions AI database. This is relatively new. It was launched in 2018, has more than 6.5 million grants. And it scrapes up using AI all grants that are put in the public domain. So anything that goes onto the internet. So it probably misses some big pharma things where they don't put things in the public domain. And that gives data on, which country, which funder, what the topic is, how much money, and so on. So we did an analysis really with our question being who funds what and why for newborns and stillbirths. So there's much more detail in the paper, but I just want to flag a couple of really quite shocking findings. So I was amazed to find that there's about $557 million a year that is spent on research that mentions newborns and stillbirths. It's actually quite a lot. Often we say people should spend more money, they should spend more money. The message here is this money should be spent smarter. Funders are putting this in. How can it get more impact around the world? Then a really shocking part here is that the stillbirths are a similar number. So if we look at this total that is for stillbirths and newborns, actually only 2% of the research funding even mentions stillbirths. And that includes in the US, where the single largest funding is allocated. And the US has more stillbirths than infant deaths, probably around 17,000 stillbirths a year, and yet are not being mentioned in research that may actually have an impact on them. There's a particularly stark geographic mismatch. So looking in detail at this, only around 40 million of these grants are allocated to low and middle income countries, 7% of the total. And yet that's 98% of the burden. And we're able to split out within the different research grants how much is spent on people and research capacity, and almost all of that is spent in high-income countries. And yet, in many ways, we need more of that spent in low and middle-income country contexts. And this is a place where I want to highlight accountability for South Africa. So a good news story in research funding for newborns and stillbirths is there is more funding going to low and middle income countries. And an impressive story within that is, in fact, that's largely driven by BRICS countries, particularly China, Brazil, and India, that you can see in this table here. But where is South Africa? Is South Africa allocating money to newborn and stillbirth research, which is really a disproportionate burden within South Africa? So I would encourage you, maybe take this paper and go and speak to some of the research funders in South Africa and see how this could be improved. What about what is the money spent on? Well, it's encouraging that the two top funded topics related to causes of death and neonatal infections and direct complications of preterm, that would be appropriate for burden. If we look at where it's spent in the pipeline, so this is the research pipeline from kind of basic lab discovery science through to delivery, a very tiny amount is spent on implementation research. So implementation research examples would be things like, you know, in a neonatal unit in South Africa, how could we change the human resource structures or data to improve outcomes? And these are critical questions, or how could we address hospital-acquired infections? Critical questions for impact now, and yet getting the tiniest part of the money. So what I want to do is to move from this research pipeline into looking at a few examples of evidence that we could take into implementation to try and speed up. And I'm only going to have one slide on the discovery science, but I want to give the message that we shouldn't knock lab science. If we don't have lab science doing the right things, we won't have new innovations coming down the pipeline that can help us to go faster. But that balance does need to be redressed. We're actually going faster in the next 5 years is really going to be driven by what we do in programs and how we have implementation science to do that well. So I'm going to spend most time on that and then a little bit of time in between on the delivery side. For the discovery side, I just want to flag some great news where South Africa has really played a key role. And this is for Group B streptococcus vaccines for maternal immunization. So making the case for this, there's new evidence showing particularly the effect on stillbirths, which really changed the cost effectiveness ratio. So it makes sense that if you have early neonatal deaths from early onset Group B strep infection, that you're also having stillbirths. And these analysis showing the major impact on stillbirths and also on preterm birth of Group B strep really helped to change the cost effectiveness ratios and have driven more investment into maternal immunization. And there are 2 vaccines that are candidates, and Shabir Madhi and his group are really involved in testing both of those. So this is something where South Africa really could gain early, as long as these vaccines are priced at a pro-poor rate and are able to be rolled out in the next few years. I want to have a few slides on development science. What do we have on devices, drugs and diagnostics, and also disruptions in care? Sometimes we look so much at the gadgets, we forget that innovations can also be health system innovations. So you and I who look after babies, we do love our machines, machines that go ping. And for level 2, WHO level 2, small and sick newborn care or neonatal care, we need around 15 device types. It's not just one. And often, particularly in the lower income settings across sub-Saharan Africa, we take what is donated or we take what arrives. And it's utterly critical that we apply science to device choice, having fewer devices that are more robust, fit for our context, Because if you have 5 different ventilation devices, you have to train 5 times, have the biomed understand 5 sets, have supplies and spare parts for 5. It's not efficient from an impact point of view. And we also need to learn to love biomedical engineers. Otherwise, what happens is we have an equipment graveyard where the equipment is no longer working and it's not able to do what it needs to do for our babies and for our families. So really critical that we think differently about this. And in the series of papers that were launched last week, there's a group of clinicians, many from across Africa, working with biomeds to say, how do we shape that device pipeline to be fit for purpose, to be lower cost, and to be able to do what was done with antiretrovirals, then bulk purchase and bring the prices down. So these 3 papers are looking at what do people want from devices, particularly for the 15 that are really needed for level 2 small and sick newborn care. Then of those devices, what do we already have on the market, and which of them really would work in these contexts? If you heat them up, drop dust on them, have lots of Escom power outages, do they still work? And it's actually depressing quite a lot didn't, including some that even go up in flames and are unsafe. But a critical point too is usability. Even if they're robust, are they also ones that people can easily apply and use, especially if we're looking for nurse-led CPAP rollout across Africa? And then how much do they cost? So this is an Excel that you can download with a list of which devices, with what we have at the moment on ratios of device per number of babies or number of beds, and then what the cost can be. And it's also fully customizable. And we would love it if some of you in USANA would like to test and improve this tool and feedback to us on how to make it useful, because we hope that this is something that can really help people to get better devices and use them better. What about drugs? Well, it's pretty shocking that in all the history of neonatal care, there's only ever been 1 drug that was actually specifically designed and tested and licensed for neonates. Most of the drugs we use are ones that we relabel. And I want to underline that surfactant was developed because of political will. So JFK, who also led the first investment for trip to the moon, because of his own family tragedy, that was how this happened. And something that I've really realized over the last couple of years is sometimes we're just too nice. Should we be saying more about what is needed for neonatal care? And then for the places where we do have proven intervention, so the last WHO guidelines last year recommended caffeine superior to aminophylline. And I don't know in detail what your situation is right across South Africa, but for most countries across sub-Saharan Africa, we're not able to get caffeine, except, for example, in Ghana, where some hospitals have taken an initiative to make that locally and package it. So we need to be much more intentional, and we need to call out what is needed and make sure that when we get things, they get to where they're needed. What about diagnostics? So clearly, especially where lab capacity is a challenge, and also where time is of the essence, having bedside diagnostics is transformative for neonatal care. We've really seen pivots, for example, in jaundice management. Some of the cutaneous bilirubinometers are not highly accurate, but there are definitely others coming out, and this has really started to move. But there are many gaps. How could we do better with diagnostics for intrapartum injury? This is the most important thing for neonatal encephalopathy and HIE. Treating after the fact is something we can do, but it would be much better if we managed to have better diagnostics for intrapartum and before labour. And then infections, I would really flag. So this is critical. Currently, blood culture is imperfect, but at least it's used in most facilities in South Africa. Across the Nest 360 Alliance, which I'll talk about later, the vast majority are not using blood culture. And then clearly for preterm, we're just not where we need to be with better diagnostics and prediction. Before I leave the discovery and come into delivery, I want to underline that not all innovations are devices or drugs. So this is kangaroo mother care, and I know that South Africa has been a real leader in this, and it's really shifted over time. It kind of started as a solution for overcrowded units, and seen in some ways as a poor person's solutions. But actually the evidence shows more and more that this is the best for wherever your baby is born who is preterm, and that absolutely makes sense as we humanize neonatal care and de-intensifies. This is an incredibly important pivot, and more rapid uptake across all regions. And I was in Karolinska, last week. It's really incredible, people rebuilding facilities and the level of care that is possible. And this is so important, but it's also easier said than done. So as well as the WHO's very important IKMC trial that has changed guidelines, there's a trial in Uganda where the results are under review at the moment, which was implemented at lower levels of facility. And IKMC has to be really on top of small and sick newborn care, including CPAP. And this is critical that we're realistic about what that will take. And if you're starting with a tiny room with very little facilities and not enough nurses, it's really important that we understand how to do that. Not to make excuses not to do it, but to make sure we do it well and make it happen. And I'm sure South Africa could contribute to that. And certainly this group in Uganda are really thinking hard about how to make this work. So I want to focus the last section of this talk on what we do to deliver for babies, both in our action for programs, but also how we think about the implementation research questions. So to underline that for the first time in history, we actually have a target, and this is really an important driver. It's an absolute target so that all countries would reach a neonatal mortality rate of 12 or less. And the current estimate from the United Nations for 2021 for South Africa is that you have reached that on national average, you're just under 12. And I congratulate you for that, because that is progress, and really substantial, solid progress over the last few years. But it hides many inequalities. On the first slide I showed you with the 4 worlds from high-income country to home birth, South Africa has all of those 4 worlds. There are gaps. Eastern Cape, the neonatal mortality rate will be much higher than this. So the good news across Africa is that most African countries have now set a target. And they have also set a specific other target that 80% of districts would have a neonatal unit that is functional. And I want to say, well, how do we then use the science to move that forward and make it happen? And this applies to South Africa also as you push forward below 11. So we need to look at a transition model for mortality, because as you reduce mortality, whether it's maternal or stillbirth or neonatal, the next mile is always a little bit harder, and you have to do more. You can't always be doing the same, especially if you want to go faster. So this is a paper in Lancet looking at a mortality transition model for maternal, newborn and stillbirths. But I want to make it much more practical for us from the neonatal side. And this is a paper that Ola Sagstad and Zolfi Buta and I and Chinyere Eziaka published in Neonatology this year, really trying to say what are the practical things we need to do to get to the next phase in neonatal mortality reduction. So this figure is showing the UK and the US and their transition in neonatal mortality from the year 1900. Now, as a fake Brit, I can definitely say there are lots of things we don't want to learn from the UK, including lots of our politics at the moment, I'm afraid. But if you look at the UK and the US, they reached a neonatal mortality rate probably around 1980. And that was before full scale up of full intensive neonatal care. Sub-Saharan Africa, on average, is around 27, Southern Asia around 23. So we are expecting a transition with a remarkable need for change maybe 3 times faster for many countries in a short amount of time. How are we going to do that? Well, most countries have already passed these first phases, what you do at home for clean, safe birth. In most of these contexts now, that most births are in facility. Tanzania, where I was just last week, has hit 81% of births in facility. But if you move forward into where most countries are now, improved maternity care, higher quality of that, but also special neonatal care, and then where South Africa is now, intensive care, and moving that across the country, really with a focus on disability-free survival and getting down to a true level of preventable neonatal deaths, which is less than 5. So what about countries that have gone faster than the UK and the US? We have more in our hands. We should be able to go faster now. And China is the fastest reducing in the world at about 8% per year. They did pretty much what is needed for South Asia and Sub-Saharan Africa in a similar time period to what is needed. And how they did that was really industrial implementation, building units, training staff, bringing in equipment. There are also things that we wouldn't maybe want to copy. So, for example, leaving families out of units, not allowed to visit. But things that we see there were really the investment and the implementation. So this is taking all the current countries of the world and seeing where they are now. And as I said, we often live in a pie from the past. There's no country with a neonatal mortality rate of more than 45. Many of these countries with a higher neonatal mortality rate are places with humanitarian contexts. And this is where most of the world's births are in this phase here. And this is where South Africa is, and this is where the SDG of 12 lies. And so what you have just gone through in scaling up level 2 care and moving towards intensive care is exactly what is needed across Africa, and is what is happening in both Bangladesh and India and Nepal, all of which are now going faster. And a critical lesson learned is to keep the package as basic as possible to get the impact needed. So the impact is particularly driven by respiratory support for babies with preterm birth, by infections management and prevention, and then also by hypothermia and KMC. So those are the things that drive most. If we start to add much more complex care into the basic package, it makes it harder to get to everybody with equity. So it is important that we get to everybody with equity before we add too much complexity to our package. That's an important learning of primary healthcare. But we know that we can't just do one thing. It's not vertical like one vaccine. We need workers, we need technologies, we need data systems, we need really to enable families to be in. We can't repeat the mistakes that were made in high-income countries, keeping families out. So this is Chikonjetso, and all of you as neonatologists will many times have seen a baby like this, 28-weeker with respiratory distress, who was saved because of improvised CPAP. That's not really, what our aim is. And this is Chikonjetso age 2. Chikonjetso means the conqueror. And for you and I, who are working on neonatal care, our aim is that every baby across Africa should be able to be a conqueror and to survive and thrive. And they shouldn't survive with blindness. At the moment, we're really rolling out a lot of unsafe oxygen use across Africa and not tracking this. And this, I think, is something that South Africa could help support on. We're also not following up enough. And this map shows continents of the world. And in each continent, how many long-term cohort studies there are generally, very few of which actually were neonatal cohorts. Utterly critical to have more cohorts. Yes, we need some that are topic specialists like neonatal encephalopathy, but we also need more general cohorts and to be able to know what is happening. So I want to spend the last few minutes especially talking about how can we make this go faster. and learning from China that I've mentioned, but also India. So India has had this amazing government leadership with major government investment on building neonatal units across the country. And this changed from 18 units to, in fact, now more than 900, has primarily been funded by government, but at multiple levels, and so much learning. And one of the things that every time I go there, I learn particularly on is on their data system. So India, one country, of course, many contexts across that. But across Africa, we have 46 countries. So how can we go faster instead of each country inventing their own data tool, inventing their own components? So that's what the Nest 360 Alliance is about. And we would love to ally with you in USANA. This is working across 4 African countries, about to be Ethiopia, which will be half of Africa neonatal deaths. 20 organizations, 15 from Africa and 5 African governments, and looking at how do we put together this package so that together we can learn and share and co-create and go faster. And to do that, WHO and UNICEF have helped us with saying, you know, what would the components be? Because many of the changes we need are not fully in control of the neonatal unit. It also needs money and infrastructure and human resources, which we don't always control on the newborn ward. And so WHO have put out these 10 components. And I would really appeal to all of you to join and be part of this implementation toolkit. We now have 21,000 unique users across the world just this year. Bring the things that you have learned in South Africa and share things. And how can we do things like have comparable data sets and move together? Last week, I was in Tanzania, and I just was so impressed to see the leadership across Tanzania for change. In this meeting on World Prematurity Day, the ex-president of South Africa, Kikwete, was there. There were about 1,700 people there for a maternal newborn child health conference, but they really recognized they needed to do so much more for neonatal health. And 100 new units have been committed to, and I believe that they will do that. This is so impressive. And if we look at how that will be financed, the government, and this is working with some Kenyan colleagues of mine, developed an investment case to say we need to reach 146 districts, 27 regional centers that will be level 3. How much will that cost? What are the cost drivers? Let's plan learning from other programs. How much will that cost? And make sure that we set out to get that money. And, you know, not surprisingly, the setup costs are really driven by infrastructure, but the running costs are driven by human resources, and especially nurses, and a big gap for nurses. And Tanzania doesn't have any neonatal nurse training. This would be a critical thing to address. One of the things that made a big difference in making the case is that this isn't just charity. For every £1 and every $1 invested in small and sick newborn care in Tanzania, they would get $8 to $12 back, just in deaths averted and productivity of the workforce. So we need to also make the case, not just for charity for newborns, but also return on investment. And to do that, if you're going to build 146 units, you don't want to have 146 different architects. So they have developed a standard floor plan, which actually I learned so much from their process on that. And then the president's office in Tanzania allocated immediately that this floor plan came out, another 10 million for rural units to be built, 10 million US dollars. People, utterly critical. If we just build, but we don't have nurses, we will fail. And data is fundamental. If we build, we have nurses, we have devices, but we're not measuring both what we provide, but also quality and outcomes, we will fail. And this is Malawi, where there's been national scale up of a core neonatal data set of about 55 items, which has now been used in all 37 newborn units. And most excitingly, they have live dashboards in each unit, which then mean people are using data. And that data is pretty important, especially for places where we're not doing blood cultures. So what you can see here is a number of different parameters related to infection in a dashboard on a ward. And where you're getting spikes here, there's actually hospital-acquired infection outbreaks that weren't being detected until people look back into this data set afterwards. So this is within a few weeks, 90 neonatal deaths, mostly from Klebsiella, and yet not being found and reacted to. So this is something I believe also South Africa can contribute and help to. So I want to finish by saying, why does this matter? It matters, yes, for our babies. It also really matters for women and for families. And it also matters for our workers, because it's really distressing to work in a tiny room with no equipment. We need to be much more intentional in asking for change so we can celebrate with workers like this. Wow! And I want to finish by saying, what could USANA do? So together, we need to actually know our data and use it. The socio-political scientists have officially said that neonatal people are just too nice. If HIV people had this burden, they wouldn't just be letting deaths happen. We need to really focus on systems change and particularly pick the highest impact things. If we start to bring in too many other complicated, expensive things too early, we may increase the gaps in equity. We must be intentional on the data. And again, we need to keep it small. And then we must be smarter on getting the money. We must use data to make the investment case for the right things. And then I just love the innovation that is happening across all of the world. How can we share that better? Please join us on the toolkit, share your learning and use things and bring ideas. We can transform the health of Africa's newborns. We can, but will we? Thank you.
Thank you very much, Joy, for those sobering but also practical insights into how we can look after our newborns. I think Shakti has noted some questions, so Shakti, please go ahead.
Yeah, thanks a lot, Joy. So there's a question in the chat here about how can we effectively advocate and close the gap in these outcomes in these austerity times. I think it was when you were speaking about the outcomes with the prem babies.
Yeah, I mean, I think that's the critical thing. And, you know, there is a paper that's been written about how different issues become a political priority. You know, how does HIV become a political priority? How does immunization? So I think it isn't just having big numbers. We clearly have big numbers. I think we need to be much smarter in how we use both the numbers on the problem, but also the return on investment. And we need to be much more thoughtful in having the voice of families who are affected and bringing politicians to the table. And I agree it is austerity times, but I would flag to you, if you read these two papers in Lancet Global Health, there is a lot of money being spent. And it's, you know, not that we want less money being spent on other health conditions or other things, but it's not correct if there's something that's a very large burden and could be prevented and is yet getting very, very little money. So I think we shouldn't assume that there's no money. There's a lot of money there. We need to do better at making the case for that money in the right way.
Thanks, Joy. Are there any other questions? Anyone can raise their hand and then we can actually unmute.
Can I ask a question in the meantime? Joy, the Nest 360 Alliance, do people join as organizations or as individual units?
Yeah, so Nest is part of a consortium that's working in these 5 African countries. So I think for you and the colleagues here, the most effective way, and where we would really welcome, is to join the implementation toolkit, which is broader than NEST, and is really about, you know, sharing your tools, sharing your learning, but also, you know, there would also be things I'm sure that are useful for South Africa.
Thank you.
Gugu, I see Alan has his hand up, Alan Horn, so I'm going to unmute and just allow him to ask his question. Okay, I think I've unmuted you, Alan, so you can actually speak now.
Yeah, thanks very much. Thanks, Joy. One of the things that comes up with funding is the need to start at the point of monitoring. And I often find that trying to get funding just for the purpose of seeing where we are, setting up a database that will span either small or large areas, is a difficult niche to find adequate funding for. And to me, that is the essential starting point. I know that there's funding for vast programs and for epidemiological research where additional samples are taken to see what else is going on. But just a basic database where we've got researchers who are funded to collect the data from the hospital records, where we've got researchers who are funded to do the follow-up, where the patients will be funded to come to the follow-up, because follow-up is something that no government is really going to put money into, I don't think, in the first or the developing world. So there are some things that are, of course, the governments should be supporting them and should be knowing what's going on, but everyone's got a different way of doing it. So do you have any suggestions regarding forums? I mean, I see the NHI funding alerts, and I see lots of funding calls coming through, but just to create a database, a common database with researchers who could do all those roles would be the most pivotal starting point. Can you comment on that? Yeah,
thank you, Alan, and lovely to hear from you. And I completely agree. The most important thing is the data actually for use on each ward, not, you know, it should be useful at all levels. You know, how many babies are getting infections, how many babies are getting appropriate treatment, how many are getting CPAP, how many are getting KMC, what the outcomes are. And in the NEST 360 Alliance, we learned from India. So India developed a standard data set that initially, you know, was co-designed and set up by UNICEF. It actually has quite a lot of variables in it, and it does link to follow-up, and it's now entirely funded by the government, and they admit 1.2 million babies per year into that. So we thought about how does that work across Africa. So part of the NEST 360 group, and that's one of the papers that came out last week, was saying how do we get a small enough data set to start in a routine situation in Africa. So I would say South Africa can afford this. It's picking how to do it. Malawi is affording it. So the Malawi government is paying for data collectors in their neonatal units who do as parsimonious as possible standard neonatal data set, which is being entered at the time of discharge now, but will transit to being electronic, you know, during admission. It's being organised by their DHIS2 system. It's held on their DHIS2 server. There are dashboards on each ward, and also then allows the country to track outcomes. And that's being done at a very affordable cost. And it's going to start in Ethiopia next year. It's also moving across Tanzania and across Kenya. So I think that having a core data set that's used for tracking and for change and for quality, and it's used on the ward, then gives you the opportunity to do bolt-ons for research. But the first thing that we need to do is to do it for care and have people locally able to use it. And the way to do that at scale is to keep it small enough. You know, we as clinicians want to add lots. That was a big conversation. So, you know, I'd love to have separate conversations with you if that's helpful. And the paper is online. I know that Vermont, Oxford also have one that's being used across some sites in Ethiopia. It has some of the kind of higher level things in and is a bit bigger, but there's really scope, I think, for us to be able to do this across Africa. I would also say that in the UK, the neonatal data set was set up without research funding and in a similar approach, but actually with, you know, quite a lot bigger data. So, you know, people agreed to collaborate and to do a data set like that.
Thanks, Joy. It'd be great to follow up offline.
Yeah, happy to do that. And I think to do that, we have to be willing to start small and make it work everywhere, and then we can add add-ons. So, for example, in our African data set, we don't have the follow-up add-on, but India has that routinely, and it links to care as well, which is really impressive with text messages to community health workers.
Thanks, Joy. Just before I let Natasha Rhoda ask her question, I just want to read a comment from Nikki Fanika from Mowbray Maternity Hospital. And she said, thank you so much, Joy. Excellent talk as always, motivating. We need to do more. One great growing concept in the Western Cape, especially, is the important role of community-based services, so important in breastfeeding support and psychosocial support for our premature moms going home, and even for antenatal education. Thanks, Nikki. Great comment. And Natasha, I've actually unmuted you. I've actually allowed you to talk, so you can unmute and please ask your question.
Hi, everyone. Hi, Joy. Great talk. I got the end of it, and I want to greet you all warmly from Hawassa, Ethiopia. And I hope this question doesn't take us back, but the reality I'm facing at the moment is that it's quite obvious in certain parts where the NMR is still below 45, but not below 20, that the road walk to the obstetricians has not actually been done yet. So I've just come off a perinatal chat with obstetricians, talking about survival and neonatal care. And I'm just wondering if it's worth an effort for us to still bridge that and have a perinatal voice rather than a neonatal voice, because there's a lot of gains that we can get from NMRs of 30, 33 to below 20 if we look at the upstream factors. Have we missed that boat? Is it still worth it? What do you think, Joy?
I totally agree, Natasha. And I think, you know, in that phase, which is phase 3, getting from 30 to 15, the obstetric care, you know, particularly the quality of antenatal care and the quality of intrapartum care and the linkages is critical. What I would say, and this was very clear in Tanzania last week, is there's been 30 years of really investing in that. Tanzania has just seen a very big drop in their maternal mortality ratio. But actually the neonatal part, at least across sub-Saharan Africa, has just not existed at all. It's a small room of places. So I think we absolutely do need the link with obstetric, and it absolutely does need to look, you know, at the vulnerability for neonatal and especially intrapartum stillbirth. But I also think the thing we have in our hands as a neonatal community is to address that, you know, what until 2 or 3 years ago didn't even exist on the global to-do list, the neonatal care. So I think we need both. But, you know, we can't say that obstetric alone will solve everything, because, you know, it won't, I'm afraid. We're still going to have small vulnerable newborns, even if the obstetric care improves. We need both.
Yeah. Anyway, I'm going to allow someone else to ask, but thanks, Joy, and thanks for giving us this wonderful talk.
And well done for being in Hawassa. Great. Good for you.
Beautiful place.
Joy, I'm going to allow the last question, and it's Steve Valapi from Barra in Joburg. So Steve, I've allowed you to speak, so you can unmute. Thanks.
Good evening, Joy. Thank you so much for this talk. I mean, looking at the publication and the number of authors from Africa, including South Africa, that is so low. I think part of it is this competition between clinical work and time for research. What would be your advice in terms of how should we approach this in terms of creating space or creating time for researchers? I mean, in addition to the data capturers, but as an individual who's got an interest, or if you do pick up an individual who has an interest, who needs more time off. And we're often struggling with our governments to understand that time off, and also understanding from our colleagues, because also as colleagues, we're also competing to say, if we're both clinicians who are working in this ward, why should we take more time on research while we're supposed to do rounds? So how do you advise, how do we approach that to enable those who are interested in research more time?
Yes, I mean, that's just such an important question. I mean, I think that the time is a challenge. I know that the 4 years I was kind of working in Ghana as a neonatal doctor, I was totally swamped all the time, so I think time is a challenge, but I also think opportunity, funding, mentoring, leadership, peer groups, those are all things that we can bring in, and there are ways to do that. And maybe when we're at perinatal priorities together next March, if there were people who wanted to have a kind of side meeting on ideas for that and some practical suggestions. I would say another is that we need to press governments, including the South African government and research funders, to be much more serious about investing in capacity and paid time and opportunities and skills building and mentoring for clinicians across Africa and other researchers too. For changing the implementation science for neonatal care, we really need to be intentional on how that shifts forward. And we have some learning in the NEST Alliance, and it would be lovely to be able to discuss that more, maybe with some of you face to face next March.
Thank you so much, Joy. I'll take that as an offer for that. You'll run a workshop around that. Thank you so much.
Yeah, and you've been fantastic, Steph. I mean, I think, and I never used to be interested in publishing papers. The reason I do it is to change things. So I think we have a privilege. We work on something that matters. We have things in our hands, and finding ways to. But the papers that were published last week are really about quite practical tools to change things.
Thanks a lot, Joy, and thanks everyone for the questions, but I think we've run out of time, so we actually are going to have to close. I'm going to hand back to Gugu, and on the screen is our upcoming webinars for next year, March and June, so please diarize them, but we will share more details closer to the time. And thanks again, Joy, and thanks to SAPA as well for allowing us to collaborate with them today. Back to you, Gugu.
Thank you, Shakti. Thank you very much again to Joy for the interesting talk and discussions. And we hope we will see you in March when you are here. And to everyone else, hope to see you at Usana. And have a good evening.